¿Qué tal? Buenas noches con todos los presentes. El día de hoy, siguiendo con las actividades del Consejo Científico de Enfermedad Coronaria, tenemos el tema el uso de imágenes por tomografía computarizada cardíaca en el cuidado cardiovascular. Mi nombre es Giancarlo Valle González, soy cardiólogo del Hospital Nacional 2 de Mayo, y el día de hoy tenemos, sí, estamos agradecidos de tener al doctor Yelani Gran, quien va a estar a cargo de la presentación. Una breve introducción acerca de él. Él nació en Trinidad y Tobago, donde completó su grado médico con distinciones en la Universidad de las Indias Occidentales y completó su residencia en medicina interna en el Hospital Jackson Memorial y la Universidad de Miami, donde fue el primer graduado extranjero en ser jefe de residentes. Actualmente labora en el Hospital Johns Hopkins, donde fue reciente ganador del prestigioso premio Northwestern Cardiovascular Young Investigator en el año 2023 y del premio John Hopkins Silverman por excelencia en investigación entre los fellows de cardiología en el año 2024. Él es experto certificado en lípidos y en imagen cardíaca por tomografía, tiene mucho interés en evaluación de riesgo cardiovascular, reducción de riesgo cardiovascular y en expandir el screening de ello en las poblaciones minoritarias. Su línea de investigación actual se enfoca en la implementación de sistemas que aseguren el reporte y manejo de la calcificación coronaria incidental con el objetivo de tener un aprendizaje automático profundo e identificación temprana de la falla cardíaca, estadio B, usando la ecuación PREVEN-HF. Welcome, Jelani, and thanks for your time. I let you with a presentation.
Awesome. Thank you, Giancarlo. So today we're going to talk about the use of cardiac CT imaging in cardiovascular care. I have no disclosures, and a little bit about me, which Giancarlo went through already, so I'll skip this slide. And I wanted to apologize for missing the last session. So lo siento, me perdí la última sesión. Es culpa de la bebé Leila. So lo siento. The objectives for this talk would be 1, to define the coronary calcification, 2, review the fundamentals of CAC scoring or coronary artery calcium scoring, review guideline and expert consensus decision-making pathway recommendations for CAC scoring, discuss what is incidental CAC scoring and the use of machine learning, review the fundamentals of coronary CT angiography, compare the differences between CAC scoring and coronary CTA. We're going to discuss a little bit the ischemia trial because it informs when we use coronary CTA in stable chest pain. We're going to review the 2021 chest pain guidelines and the 2023 chronic coronary disease guidelines and the role of coronary CTA in both of those US guidelines. And then I have a couple cases where we can apply what we've learned throughout the next hour to those case-based approaches. Most of what I'm presenting is based on the way we practice here at Johns Hopkins, and I'm interested to see if you guys have different thoughts or so on. So let's start with a case. We have a 58-year-old man. He has no known medical history, and he comes to the emergency room for a cough and shortness of breath. He underwent a CT of the chest and was diagnosed with a pneumonia. The cardiac component of his CT is shown below. I want you to remember this image, formulate a plan in terms of what you would do in your hospital or your practice. And at the end of this presentation, we'll get back to how would you manage this patient. So other than treating his pneumonia, does he warrant further cardiac workup? And if so, what do you recommend? The first thing is understanding what is coronary calcification. There are 3 main types of calcification. The first one is infantile, and that's seen in large and medium vessels, mostly in infants and kids, so not relevant to adult cardiologists. Then there's a medial or Mockenberg calcification, and that's mostly in the tunica media. So if you look at B in this figure here, it's calcification in the tunica media and the internal elastic lamina, and that's seen in calcification from renal disease. So you have those patients with end-stage renal disease who have a lot of vascular calcification. That's the type of calcification you're going to get. And what we're most interested by is intimal or atherosclerotic calcification, which occurs mostly in the intimal region or subintimal. And that is what we're looking to identify on a non-gated, non-contrast CT of the chest, and it's known as coronary calcification. The presence of intimal coronary calcification does not mean that there's obstructive atherosclerotic plaque. If you look at the top figure on the right, it's showing different types of plaques. So you have plaque erosions, acute ruptures, vulnerable plaques, and healed ruptures. And if you look at each of them, there's a certain proportion of them that have no coronary calcification. So I want to make sure that we understand that having coronary calcification, while it does increase your risk of future ASCVD, and it's a marker which we use to treat patients with preventive therapies, it does not mean that you have obstructive atherosclerotic plaque. There's a difference between calcified and non-calcified plaque. What we're identifying on this non-contrast CT is calcified plaque. And when we get into coronary CTA more, we're going to talk more about non-calcified plaque. Simply put, the greater the percent of coronary stenosis, the greater the probability that there will be some component of calcified plaque. The fundamentals of CAC scoring. So we use non-contrast, non-EKG gated CT scans to detect coronary calcification.
Jelani.
Yeah.
Hi. Can you give a pauses for the translate, please?
Can I give a what?
Pauses for the translate, please. For translate the presentation, for the translator. We need...
Sorry, can I give a what?
If you could please give me time so I can translate what you're saying, and if we can start again, actually.
Okay, so we're going to translate slide by slide.
Pauses. This is the interpreter. If I'm doing consecutive interpreting, I need you to make pauses so I can speak after you for each sentence.
Okay, so do you want me to go slide by slide? You're going to interpret it. Is that the plan?
Not necessarily the whole slide, but giving me short sentences so I can say what you're saying.
Okay, do you want me to start over?
If it's possible, because I didn't have any time to translate what you were saying.
Okay, I'm happy to start over. Are we good to go? Are we good to start? Translator, are we good for me to start?
Yes, please, and if you could speak loud and clear,
okay,
that will be great.
So as Giancarlo mentioned, I am Jelani Grant. I'm a final year fellow in cardiology at the Johns Hopkins Hospital. I will be discussing the use of cardiac CT imaging in cardiovascular care.
Buenas noches, tal como Giancarlo mencionó, yo soy un becario del Hospital Johns Hopkins. Voy a hablar el día de hoy sobre el uso de tomografías computarizadas cardíacas en el cuidado cardiovascular.
I have no disclosures.
No tengo ninguna divulgación por hacer.
And I would like to apologize for canceling on the last session. My wife went into labor and we received our baby girl, Layla.
Lamento no haber podido estar en la última sesión. Mi esposa entró en trabajo de parto y tuvimos una bebé llamada Leila.
So let's get started. Objective 1 is to define coronary calcification.
En primer lugar, tenemos el objetivo número 1, que es definir la calcificación coronaria.
Next, we're going to review the fundamentals of CAC scoring.
Vamos a revisar los fundamentos del puntaje CAC.
Then review guidelines and expert consensus decision-making on the recommendations for CAC scoring.
Vamos a revisar los lineamientos y las recomendaciones SDP para el puntaje CAC.
Next, we're going to discuss incidental CAC scoring and the use of deep machine learning.
Vamos a conversar sobre el puntaje CAC incidental y el uso del aprendizaje automatizado.
Review the fundamentals of coronary CT angiography.
Vamos a revisar los fundamentos de la tomografía computarizada de angiografía.
Compare the differences between CAC scoring and coronary CT angiography.
Vamos a comparar las diferencias entre el puntaje CAC y las angiografías computarizadas.
We are going to discuss the ischemia trial in detail.
Vamos a ver en detalle el ensayo de isquemia.
We are going to review the role of coronary CT angiography in the 2021 chest pain guidelines.
Vamos a revisar el rol de las angiografías computarizadas de acuerdo con los lineamientos de la enfermedad coronaria crónica,
And the 2023 chronic coronary disease guidelines.
de acuerdo con esta versión del 2023, y también el rol de CCTA de acuerdo con la versión del 2021 en dolor de pecho.
And I have a couple cases which we're going to use to apply what you've learned today.
Y vamos a ver un par de casos donde vamos a poder aplicar lo que aprendemos el día de hoy.
So let's start with case 1. There's a 58-year-old man with no medical history who presents to the emergency room with a cough and shortness of breath.
Entonces tenemos el caso número 1, donde tenemos a un hombre de 58 años sin ningún historial médico que se presenta en la sala de emergencia con tos y dificultad para respirar.
He underwent a CT scan of the chest and was diagnosed with a pneumonia.
Se le hace una tomografía computarizada al pecho y se le diagnostica neumonía.
The cardiac component of his CT scan is shown below.
El resultado de la tomografía computarizada se muestra en la parte de abajo.
I want you to remember this image, and I'll get back to it after my presentation is over.
Quiero que recuerden esta imagen porque voy a volver a ella una vez que termine mi presentación.
At your institution, other than treating his pneumonia, do you review these CT findings? What are the findings? And do you recommend any further cardiac workup?
En su institución, ¿ustedes cómo tratarían esta neumonía? ¿Solo tratarían la neumonía o tratarían de tener algunos otros hallazgos? ¿Qué es lo que ustedes recomendarían?
To discuss CAC scoring, you need to understand the biology of coronary calcification.
Lo primero es que tenemos que entender la biología de la calcificación coronaria.
There are three types of calcification.
Hay 3 tipos de calcificación coronaria:
The first is infantile,
infantil,
which is seen in large and medium vessels in children.
que se observa en las venas grandes y medianas en los niños.
Second, there is medial or Mockenberg calcification.
También tenemos la calcificación media o Mockenberg,
And the calcification occurs in the tunica media or internal elastic lamina.
y también tenemos la calcificación íntima o de aterosclerosis.
And it is seen in calcification from renal disease.
Sorry, can you repeat that?
Medial calcification is seen in calcification from patients with renal disease.
La calcificación media se observa en pacientes con problemas renales.
And Intimal calcification is what is seen in coronary calcification or atherosclerosis.
Y la calcificación íntima es lo que se ve en la calcificación coronaria o aterosclerosis.
And this is located in the tunica intima.
Sorry, can you repeat that? I can't hear you properly.
This is located in the tunica intima.
Está ubicado en la zona íntima.
Correct. The presence of intimal coronary calcification does not equate to the presence of obstructive atherosclerotic plaque.
La presencia de la calcificación coronaria intimal no es igual a la presencia de una placa aterosclerótica obstructiva.
If you look at the figure to the top right of this slide,
Si ven la imagen en la parte superior de la diapositiva al lado derecho,
you can have various types of plaque,
pueden ver diferentes tipos de placa,
erosions or ruptures,
erosiones o rupturas,
but this can happen in the absence of coronary calcification.
y esto se da en la ausencia de la calcificación coronaria.
Therefore, you can have erosions or rupture to calcified plaque or non-calcified plaque.
Entonces, podemos tener erosiones o rupturas en placas calcificadas o no calcificadas.
If you look at the figure on the bottom right of this slide,
Si ven la imagen en la parte inferior derecha,
you will see that as the percentage stenosis of a coronary artery increases,
van a ver en los porcentajes cómo se van elevando
that the prevalence of that plaque containing any calcification also increases.
y las placas que no tienen calcificación también incrementan.
The fundamentals of CAC scoring
Los fundamentos del puntaje CAC
is that this is a non-contrast EKG-gated CT scan of the chest.
Estamos hablando acá de los ecocardiogramas que se realizan al pecho.
And by EKG-gated, I mean that the images are acquired during diastole.
Y estas imágenes son requeridas en ciertos momentos.
And we use something called the Agatston score to calculate the amount of coronary calcification.
Y utilizamos nosotros el puntaje Agatston para calcular cuál es la cantidad de calcificación coronaria.
So the first step is looking for any calcium within the coronary arteries.
Así que lo primero es ubicar si es que hay calcio en la parte coronaria.
And that's looking at a density or a Hounsfield unit of greater than 130.
Y aquí tenemos que ubicar una unidad que tenga una densidad mayor a 130.
Next, we calculate the area or how much of calcium there is in terms of area.
Luego calculamos cuánto calcio hay en términos de área.
Each one of the Hounsfield units is graded in terms of 1, 2, 3, 4.
Cada unidad recibe un valor de 1, 2, 3 o 4.
So if it's between 130 to 199, it's 1.
Si va de 130 a 199 es 1.
200 to 299 is 2.
De 200 a 299 es 2.
300 to 399 is 3.
300 a 399 es 3.
And greater than 400 is 4.
Y más de 400 es 4.
So for example, for the patient on the left, the area is 15 millimeters squared.
Entonces, en el lado izquierdo, por ejemplo, en este caso tenemos un área de 15 milímetros al cuadrado.
And the peak Hounsfield units are 450, which gives us a unit of 4.
Y 450 unidades Hounsfield, lo cual nos representa el número 4.
So 15 multiplied by 4 is 60.
Si multiplicamos los 15 por 4 nos da 60.
And you do that for calcium throughout different vessels, and the sum of that score is your Agatston or CAC score.
Lo que hacemos es hacer esta multiplicación por cada unidad y con eso obtenemos el puntaje CAC.
One of the biggest criticisms of CAC scoring is radiation exposure.
Una de las críticas al puntaje CAC es la exposición a la radiación.
However, you are only receiving about 1 to 2 millisieverts of radiation exposure.
Sin embargo, solamente se está exponiendo a 1 o 2 millisieverts de radiación,
which is less than the average US national background radiation per year,
que es de hecho menor a la radiación por año según el puntaje nacional de los Estados Unidos promedio.
less than a nuclear stress test,
También es menor a una evaluación de estrés nuclear,
less than cardiac catheterization,
es menos que una cateterización cardíaca,
less than a non-gated CT scan of the chest done for non-cardiac reasons,
también menor a una tomografía computarizada del pecho realizada por razones que no son cardíacas,
and slightly above or similar to a screening mammogram.
y un poco más o muy similar a una mamografía.
If you look at this image, what I'm trying to show is at what point does a CAC score pick up atherosclerotic plaque.
Aquí, en esta diapositiva estamos viendo con qué puntaje se puede comparar esto con una enfermedad coronaria.
Intimal thickening occurs before atherosclerosis develops.
El grosor intimal se realiza después de que hay aterosclerosis.
But when you start developing calcium,
Cuando se comienza a desarrollar calcio
within the intima
en el intimal,
of the atherosclerotic plaque,
tenemos también la placa de aterosclerosis.
that's where CAC scoring or coronary artery calcium scoring can identify disease.
Ahí es cuando el puntaje CAC puede identificar una enfermedad.
So it is an early marker of heart disease, but not the earliest marker.
Entonces podemos identificar estas enfermedades del corazón, pero no de repente a etapas tempranas.
We will get to it later, but coronary CTA identifies atherosclerotic plaque earlier on in the disease before calcium occurs.
Con este puntaje podemos identificar la enfermedad coronaria antes de que aparezca el calcio.
What do current guidelines state?
¿Qué es lo que nos indican los lineamientos actuales?
The 2018 blood cholesterol guidelines
Podemos ver los lineamientos aquí.
give a class 2A recommendation for CAC scoring in intermediate risk or borderline risk adults.
Podemos dar una recomendación de clase 2A en enfermedades de riesgo intermedio o riesgo límite seleccionados en adultos.
So when you calculate your 10-year risk of ASCVD,
Entonces, cuando calculemos el riesgo 10 años,
if you implement CAC scoring in these patients, you can re-stratify to either high risk or low risk.
Podemos determinar si es que hay un riesgo alto o un riesgo bajo.
If they are high risk, then they benefit from preventive therapies like statins.
Si es que el riesgo es bajo, pueden recibir un tratamiento temprano.
If their CAC score is 0, then they're re-stratified to low risk, and we recommend lifestyle changes alone.
Si es que el resultado es 0, entonces esto es como si fuese un riesgo bajo y solamente recomendamos hacer cambios en la vida diaria.
When we compare negative risk markers,
Cuando comparamos los marcadores de riesgo negativos,
and this includes looking at carotid intima media thickness,
para determinar si hay enfermedad en alguna de los tipos de calcificación,
high sensitivity CRP that's normal,
tener una sensibilidad alta es normal,
and many other biomarkers or risk markers,
y muchos otros biomarcadores de riesgo.
a CAC score of 0 is the strongest negative risk factor for the development of ASCVD.
Si tenemos el marcador 0 en CAC, este sería el factor de riesgo negativo más fuerte para el desarrollo de la enfermedad de esteroesclerosis.
More importantly, this was a study that was done by a colleague of mine in Circulation a few years ago.
Este es un estudio que realizó un colega mío hace unos años. Está circulando actualmente.
And on the x-axis, you have CAC scores.
Podemos observar los puntajes CAC en la parte de abajo.
And on the y-axis, you have your annualized 3-point MACE rate.
Y en la parte de la izquierda podemos observar el ratio de 3 puntos anual.
And if you remember the Fourier trial,
Si recuerdan el ensayo que mencioné,
it looked at the use of PCSK9 inhibitors for LDL cholesterol lowering in secondary prevention patients.
podemos ver una baja de colesterol en pacientes secundarios.
These were patients who had an MI, a heart attack, or ASCVD in the past.
Acá podemos observar si es que el paciente ha sufrido de cierta enfermedad en el pasado.
And what this slide shows is if you look at this line at a CAC score of 1,000, the 3-point MACE rate was similar to the placebo group in the Fourier trial.
Si observan la línea en el punto de 1000, van a ver que es similar al resultado del efecto placebo.
Which is important because it means that in primary prevention populations, if your CAC score is that high, it's the same risk as if you've had a heart attack before.
Lo cual es importante porque significa que en las poblaciones primarias, si es que el resultado es alto, es como si hubieran tenido un ataque al corazón antes.
And this informed the 2022 ACC Expert Consensus Decision-Making Pathway on Non-Statin Therapies.
En el 2022 se hablaron sobre las decisiones respecto a las terapias no statin.
So again, for intermediate risk patients, they recommend CAC scoring.
Así que para los pacientes con riesgo intermedio se recomienda el puntaje CAC.
If your score is between 1 to 99, they recommend moderate intensity statins.
El puntaje es de 1 a 99 y se recomienda una terapia statin de intensidad moderada.
If it's more than or equal to 100, they recommend moderate or high intensity statins.
Con un puntaje CAC mayor o igual a 100 se recomienda una terapia statin de alta intensidad, de intensidad moderada a alta.
And if it's more than or equal to 1,000, they recommend high intensity statin therapy.
Con un puntaje CAC de igual o mayor a 1000, se considera una terapia statin de alta intensidad.
And furthermore, based on that previous study that I showed you, they are saying that if your CAC score is more than 1,000 and you've already considered a high intensity statin and you get more than 50% reduction in your LDL cholesterol.
Y además, si es que tenemos un puntaje de más de 1000 y estamos considerando la terapia de alta intensidad, también se puede observar una reducción mayor o igual del colesterol.
And your LDL cholesterol is still not less than 70, then you should add on ezetimibe.
Y si es que el colesterol no es menor que 70, se debe considerar el ezetimibe.
And this is the same threshold for secondary prevention patients, LDL cholesterol less than 70.
Esto solamente para los pacientes con colesterol menor a 70 como prevención.
Even though the European guidelines and this same document states in very high-risk patients, we push that threshold to less than 55.
Nosotros nos mantenemos en utilizar el umbral de 70.
And so much so that if you add ezetimibe and you're still not at goal, then it's reasonable to consider a PCSK9 inhibitor.
Si es que no eres un adulto, se podría considerar utilizar un inhibidor PCSK9.
Simply put, in our clinic, we've been able to get PCSK9 inhibitors approved for primary prevention patients based on a CAC score.
En nuestra clínica ha sido aprobado que podamos utilizar este inhibidor PSK9 en los pacientes primarios a manera de prevención.
CAC scoring can also be used to inform the risk versus benefit discussion for aspirin in primary prevention.
También podemos observar los beneficios netos de la aspirina de acuerdo con los puntajes CAC.
10 to 20 years ago, all my patients had aspirin for primary prevention.
Hace 20 años, los pacientes tomaban aspirina a manera de prevención.
But what we have found is specifically in older patients or patients with a higher than normal bleeding risk, the benefit of aspirin has become questionable.
Observamos que había un resultado positivo en los pacientes que tenían propensión a sangrado alto.
But what I caution against is stopping aspirin in everyone for primary prevention because it's a decision that needs to be made in individual patients.
La decisión se tiene que tomar dependiendo del caso individual.
Now, I want you to look at this figure, and as you start from blue, orange, yellow, light green, and dark green,
Quiero que observen esta imagen. Ven el color azul, anaranjado, amarillo, verde claro y verde oscuro.
you go from all patients who had coronary artery calcium to 0 and increasing CAC scores.
Aquí están los pacientes que tenían la calcificación coronaria y pueden observar cómo los puntajes se han ido reduciendo.
The numbers at the top of each bar graph is the number needed to treat.
El número que observan encima de las barras es el número de pacientes que tenían que ser tratados.
And if you read the red line, that's the number needed to harm.
Y también pueden observar la línea roja, que es el número de pacientes que sufrían de la enfermedad.
So for example, if the number needed to treat for a CAC score of greater than 400 is 100,
Aquí tenemos aproximadamente 100 pacientes que necesitaron recibir el tratamiento.
and the number needed to harm is 347,
Y acá podemos observar el número 347.
Then I can use a CAC score to say that this patient will receive more benefit compared to harm for aspirin for primary prevention.
Entonces estos son los pacientes que se iban a ver beneficiados por el uso de este tratamiento.
Translator, I think Giancarlo wants me to proceed without the translation. Translator, can you hear me? Okay, I'll be continuing without the translator. Other than aspirin use, we can use coronary artery calcium scoring to inform blood pressure control. If you look at this graph on the left, what this is at a CAC score of 250, we found that the risk of ASCVD in the future was similar to patients who were enrolled in the SPRINT trial. Simply put, you can use a CAC score to derive benefit for more intensive blood pressure control in patients who are higher risk. So in our clinic, we spoke about using CAC scoring to intensify lipid-lowering treatment, including PCSK9 inhibitors. We spoke about CAC scoring to inform the risk versus benefit discussion of the best patients to derive benefit for aspirin for primary prevention. And now for the SPRINT trial, if patients come to my clinic and they have subclinical atherosclerosis by a CAC score greater than or equal to 100, those are the patients that I really want to treat with intensive blood pressure control. But nothing is more expensive than a missed opportunity for prevention. And we spoke a lot about dedicated CAC exams, which we said are EKG gated. In the US, patients have to pay out of pocket because it's not covered by insurance. And it's a separate test that you have to send patients for. But the important thing, and it's the foundation of a lot of my research, is something called incidental coronary artery calcium. And this is doing a CT scan for non-cardiac reasons, meaning for a pneumonia, for lung cancer screening, and on that non-gated scan, looking for coronary calcification. Multiple cardiology and radiology guidelines in the US recommend routine reporting. However, it's not reported. And there are 13 million CTs of the chest done yearly compared to 60,000 CAC exams, which means that it provides us with a much greater opportunity to identify coronary calcium and treat heart disease. How easy is it to report coronary calcification? The answer is very easy. This is a paper we published in the Journal of Clinical Lipidology. And I encourage you, when you have your patients who undergo a CT scan, like the patient in case 1, look at the films, look at the LAD, the circumflex. The right coronary artery is not that well visualized because it's not a gated scan, and you're looking for the calcification. If you see no calcium, it's reported as none. If you see isolated flecks, it's reported as mild. If you see long continuous segments of calcium, it's severe. And anything in between mild and severe is moderate. The important thing is that moderate to severe coronary calcium identified incidentally correlates with a CAC score on a dedicated exam of greater than or equal to 100, which is a guideline recommendation for statin therapy. This was a secondary analysis of the National Lung Cancer Screening Trial, and all they showed is that in patients who underwent lung cancer screening CTs, and these were elderly men mostly who smoked, whether you use the traditional Agatston scoring or the visual method that I just discussed, it similarly predicted coronary heart disease, and the visual method was much faster and easier to report. This was an implementation study, that my mentors and I did when I was at the University of Miami. And what we wanted to do was in 2019 understand how often radiologists were reporting incidental coronary calcium on either routine CT scans done for non-cardiac reasons or those done specifically for lung cancer screening. We undertook a 2-year process of educating cardiologists, radiologists, internal medicine doctors, surgeons by sending emails, creating infographics, having conferences, and then we changed the reporting template. So any radiologist or cardiologist reading a CT scan of the chest had to mention the presence or absence of coronary calcification. We repeated that convenience sample in 2022 to see how well we were doing. And because we were getting a lot of pushback from radiologists, we validated a deep machine learning algorithm to automatically report incidental coronary calcification. We sent a survey to the radiologists to understand why weren't they reporting coronary calcium. And 33% of them believed that reporting incidental CAC improves clinical decision making. 75% of them were not confident in reporting coronary calcification. 60% of them believed that a deep learning aid would improve incidental CAC reporting. And almost 90% of them thought that using deep machine learning would improve their confidence reporting incidental CAC. If you look at this graph or figure, this is what we were able to achieve. If you look at the darker bars, that was before our intervention, and the lighter bars were after our interventions. So moderate incidental CAC was not reported in the impression of the report at any CT scan that was done. But when we made our change and we educated people, that increased to 80%. Severe coronary calcium was only reported in 4.8% of cases, but after our intervention, that increased to 93.5%. And then mentioning the severity, so not just saying that CAC was present, but specifying whether it was mild, moderate, severe, we increased moderate from 0 to 80% and severe from 0 to 93.5%. The findings were similar when we isolated them to the lung cancer screening group, albeit it was not as impressive as the others. This is an interesting study that was published in JACC in 2023 from colleagues in Stanford. And what they demonstrated is that using almost 6,000 patients, they used this deep learning algorithm to identify coronary calcium, and they found that it predicted all-cause mortality, death, MI, or stroke, or higher odds of death, MI, stroke, or revascularization. Beyond that, they took it one step further. It's using this deep learning algorithm. This was called the Notify-1 trial. They took pictures of the coronary calcium and they sent it to patients or clinicians. And then they had a usual care arm where they delayed the notification for 6 months until after the study was done. And they found that they were able to increase the new statin prescriptions from 6.9% to 51.2%. Moving forward to coronary CTA, what are the fundamentals? It's most commonly prospective EKG gating because it's a lower radiation dose. Here you require IV contrast because you want to visualize a non-calcified plaque. You require heart rate control. So at our institution, we have a protocol with beta blockers and ivabradine to slow the heart rate to about 60 beats per minute. And this is to avoid motion artifacts. And the coronary CTA visualizes calcified and non-calcified plaque. It's important to know that when your CAC is equal to 0, the presence of non-calcified plaque is approximately 5 to 16%. For now, coronary CTA is reserved for symptomatic patients with either acute or stable chest pain, and it may be contraindicated or difficult to image in patients who have allergies to iodine, who have renal impairment, or an inability to lower their heart rates or arrhythmias like atrial fibrillation. This was a paper in JACC, and it shows comparing coronary CTA to an invasive cardiac catheterization. The sensitivity ranged from 85 to 99%. The specificity, excluding the second study, was between 70 to 90%. The positive predictive value was largely in the 80s to 90s, and the negative predictive value was between 88 to 98%. Going back to this figure, the first figure I showed you, you were only able to use CAC scoring to identify calcified plaque, but that was the later end of atherosclerosis. Coronary CTA allows you to identify fibroatheromas and pathologic intimal thickening. So you're moving from identifying plaque, which would be in this region, which is calcified plaque, to way before, which is why we're able to identify non-calcified plaque. So much so that there's something called vulnerable plaque, which we look for in a coronary CTA, and these patients are at a much higher risk for an acute coronary syndrome or heart attack in the 2.45 years following the scan that shows this vulnerable plaque. And this was elucidated or showed in the Scott Hart trial. The first one in A is low attenuation plaque, and that's plaque where your Hounsfield's units are less than 30. Positive remodeling, if you look here, the diameter of the coronary artery is here, but there's a region where you start getting a little bit of widening of that lumen from atherosclerotic plaque, and then it narrows again. So when the lesion plaque area is greater than the reference lumen of the coronary artery, that's positive remodeling. There's also the napkin ring sign, and there's lastly spotty calcifications. Remember, when these are present, your risk of an acute coronary syndrome is much higher than normal, well, not normal, but non-calcified and calcified plaque. Understanding the difference between CAC scoring and coronary CTA, on the left, simply answering, is there calcified plaque, yes or no, and how much calcified plaque is there? And that's going to inform preventive therapies. A coronary CTA can answer, if I don't see any plaque within the lumen, there's no coronary artery disease. If I see plaque, but it's not obstructive, there's a minimal, and again, I'm going to push preventive therapies. If there's a mild stenosis or non-obstructive disease, again, preventive therapies. If there's a moderate stenosis between 50 to 69%, if it's atypical chest pain and I'm not entirely sure, I can use CT-FFR to get a better idea of if that's a functional or obstructive lesion. And if it's typical chest pain and I'm really worried, then I'm either trying to get a functional stress test or sending that patient for an invasive coronary angiogram to answer my question. And if it's more than 70% or it's obstructive, then it tells me that that's an obstructive lesion. This is from the Society of Cardiac CT, and it gives a framework for the practical uses of coronary CTA. First-line tests for evaluating patients with coronary anomalies. So if someone comes to me, it's a young patient, he had a syncopal episode or a chest pain syndrome, I think that they're not going to have a lot of calcium. I think that I'm going to get really good images from a coronary CTA. I'll get a coronary CTA to define that coronary anatomy because I can get a clear idea if there are coronary anomalies present. Some patients who had a prior CABG, I don't know if you guys have ever been in those cath lab cases where it's taking forever to find the grafts. Where did the surgeons put the graft? You know, getting a coronary CTA before, if for some reason you're doing a CT before, will help you to locate those grafts so that when the interventional cardiologist is looking, it's much easier to figure out which grafts are occluded and which grafts you should be going for. I'll put a plug in to say, even in non-contrast CTs, we still use them to get an idea of graft patency before a cardiac catheterization, because you can get an idea of where the grafts are running. It's a first-line test in patients who have no history of coronary artery disease, stable coronary artery disease, or atypical chest pain, and you want to get a better idea of, is there left main disease, is there multivessel disease in a diabetic patient? That will help inform management. It's also reasonable, but less often used in patients who have coronary stents, but it must be larger than 3 millimeters. And patients who, prior to non-cardiac surgery, with a low to intermediate probability of coronary artery disease, it's a low-hanging fruit to get a coronary CTA. This is the 2021 Multi-Society Chest Pain Guidelines, and it endorses coronary CTA use for stable chest pain. In asymptomatic patients, no further testing is recommended. In low-risk patients with chronic chest pain, the guideline really recommends considering no testing, or you can consider getting an EKG or CAC scoring because that would inform preventive therapies. And remember, your risk of future ASCVD or ACS is based on your burden of atherosclerotic disease. And identifying that with CAC scoring can help you to optimize your preventive therapies. Intermediate to high risk traditionally was functional testing, which your EKG stress testing, your nuclear stress testing. But the guideline is really encouraging you to consider coronary CT angiography for these patients, and we'll get into why that's important. If you look at this study that compared coronary CTA to exercise treadmill testing, to a nuclear stress test, a pharmacological nuclear stress test, exercise stress echo, to butyramine echocardiography, if the test is normal, your risk of an MI or cardiac death with a coronary CTA is 0.02%, meaning I can safely reassure a patient that their risk is exceedingly low if they have a coronary CTA that's normal. Whereas that risk is a bit higher in any other of the modalities. This is a 2023 multi-society guideline for the management of patients with chronic coronary artery disease. And there's a class 1 recommendation, and class 1 means it is recommended in patients with chronic coronary disease and a change in symptoms or functional capacity that persists despite guideline-directed medical therapy. Invasive coronary angiography is recommended for guiding therapeutic decision-making with the goal of improving anginal symptoms. However, if their symptoms are well controlled, you can get a coronary CTA to rule out left main disease or multivessel disease in diabetic patients, and we'll get to that. Getting to that, it's important to understand the ischemia trial. Why was the ischemia trial done? Well, there was a systematic review of more than 50 observational studies of patients with chronic coronary disease, and they found that once you had complete revascularization after PCI or CABG, it was associated with improved survival and freedom from MI. But some studies reported that it improved. Some studies reported that there was no difference. So ischemia was the randomized controlled trial after COURAGE to evaluate the impact of complete revascularization in patients with stable coronary artery disease undergoing under either an invasive approach with PCI and CABG or conservative management strategy with preventive and anti-anginal medications. So you had stable patients. They had to be proven to have moderate or severe ischemia by stress testing, and this was done with exercise or pharmacological stress testing. They underwent coronary CTA and, of course, were blinded. And if you had a left main disease, you were excluded. If you had heart failure or LV dysfunction with an EF of less than 35%, you were excluded. If you had an ACS within 2 months, you were excluded. And if you had such bad angina that it was occurring despite medical therapy, you were excluded. The rest of patients were randomized to either an invasive strategy where they were on preventive therapies, anti-anginal therapies, and underwent a catheterization. And if they were found to have an obstructive lesion, it was either revascularized with PCI or CABG. And then the other group was just anti-anginal therapy, and cath was only reserved if they were having chest pain despite optimum medical therapy. What they found was the primary endpoint was a composite of cardiovascular death, MI, or hospitalization for a cardiac arrest, or heart failure or unstable angina. And after 6 months and after 5 years, there was no difference between PCI and CABG and optimal medical therapy. The p-value was 0.34. Important limitation of ischemia to note is that the entry criteria and baseline characteristics of enrolled patients did not apply to patients who were highly symptomatic, meaning if you're having a lot of chest pain despite anti-anginal therapy, ischemia does not apply to those patients. If you had a recent ACS, doesn't apply. If you had left main coronary artery disease or stenosis more than 50%, did not apply. And if you were having New York Heart Association class 3 or 4 symptoms, or an EF of less than 35%, did not apply. So I love this figure because it provides a conceptual framework of how to approach patients who come with stable coronary artery disease. and this is from the Society of Cardiac CT. So the first thing they are wanting you to answer is, if my patient is coming with stable coronary artery disease, is there obstructive left main coronary artery disease? Is it more than 50%? Then the answer is yes. Then if you think that there's a probability that they have left main greater than 50%, that patient should be referred for cardiac catheterization and treatment as appropriate. If you don't think that they're having left main disease, then you start going down this pathway. And again, this is where you're taking your coronary CTA as a first step. So you're answering, if I see left main disease on my coronary CTA, I'm sending that patient for cath, because that patient needs to be revascularized, because we have no data from ischemia for those patients because they were excluded. The next step is, do they fit this pathway? And this pathway is going to focus on risk factor control, because remember, the burden of atherosclerotic disease determines risk. So I want to treat their high blood pressure. I want to treat their hyperlipidemia. I want to get them on a statin. I want to get their LDL cholesterol less than 55. I want to get them on an aspirin for primary prevention or secondary prevention if needed. I want to get them on a beta blocker for anti-anginal control. I want to get them on a calcium channel blocker and a nitrate for control. And importantly, I'm sending them for an echocardiogram because I want to make sure that they don't have an EF of less than 35%, because again, that was an exclusion from the ischemia trial. And we know that patients who have heart failure or EF of less than 35% and multivessel disease who are revascularized do well. The next step is, if I don't see any obstructive disease, continue risk factor control and aspirin, statin, and secondary prevention treatment. If I see moderate disease, 50 to 70%, if their chest pain is atypical or possibly cardiac, then I'll consider CT-FFR or functional testing. However, if their story is really worrisome and they're really having chest pain that I'm not sure about, those are patients where I'll probably send them to cath, and not necessarily because I want them to be revascularized, but I want to get a clear idea, is this a 70, 80, 90% lesion, or is this a 40, 50% lesion? And that gives me the answer. And at our institution, when they're on the table, we have that discussion with our interventional cardiologists. So we make their shared decision-making into which patients we revascularize and which patients we just want to know that answer and we can treat medically. In terms of patients who have obstructive disease, 70 to 100% lesions, again, risk factor control, secondary prevention, anti-ischemic therapy. And these are the patients, like one patient I had in clinic recently, where I keep adding on medications, and it's shared decision-making. I asked them, I said, we can treat this medically, or I can refer you to the cath lab where you can get stents, and that may help your symptoms, but it would not definitely reduce your risk of a heart attack or death. What do you decide? And I'll tell you, most patients want to try medications first, and if it's not working, then we understand that we've tried that, and we're proceeding for an invasive coronary angiogram with revascularization as needed. So putting that into context, my approach is I really take a detailed history for chronic coronary disease. I start medical and risk reduction therapies to lower their risk. I always get an echo to rule out a reduced EF, because if my patient is having multivessel disease and the EF is less than 35% with angina, I'm referring them for CABG. I obtain a coronary CTA to rule out left main disease, unless there's a high CAC score. And the reason being is the more calcium you have in the vessels, you get more blooming artifact. And it's difficult to really see whether it's obstructive or not. So it becomes difficult. So my cutoff is, if their CAC score is less than 300, I feel confident that I can get a coronary CTA and get answers that would help me in management. Whereas if it's somebody who's having a CAC score of 1,000, I'm probably not going to get good visualization with a coronary CTA. So I may consider sending them directly for an invasive cath or functional testing. I consider functional testing if I need objective evidence of angina and functional capacity, and I favor exercise stress testing. And I just remember, if the EF is reduced, if I have suspicion that this is left main disease, if the patient is diabetic and I suspect that they're going to have multivessel disease, or they've already failed medical management, I refer them for invasive angiography because I get more detailed answers. Well, not detailed answers, but I get answers to to specifically answer the questions that I want. An additional application of cardiac CT, which we use a lot in Hopkins, and this started with the COVID pandemic, is we use cardiac CTA to rule out left atrial appendage thrombus before cardioversion. So usually what would happen is that we'd have patients come for a TEE, we clear the left atrial appendage, but in our institution, it requires anesthesia support or moderate conscious sedation. It requires a special procedure room. It requires having the probes cleaned. And a lot of times it was difficult to get that set up. Around the time of COVID, there were multiple studies that compared coronary CTA with a TEE and found that the sensitivity and specificity were the same. It's important to know that for the cardiac CTA, it has to be a delayed phase filling. You don't need heart rate control. So what we found is in terms of scheduling patients for an electrical cardioversion, whether it's getting a TEE or a cardiac CTA, whichever one the patient is able to get first or safely, we get that done. We clear the left atrial appendage and we proceed with cardiac electrical cardioversion. So going back to the case, I'll tell you how we treat this patient. So 58-year-old man comes into the emergency room. He has a pneumonia. If you look at this CT scan, this is the left main, this is the LAD, and this is the circumflex. We can't see the RCA in this picture, but you're seeing that this guy has a moderate to severe coronary calcification. And that correlates with a CAC score of greater than or equal to 100. So even though he came for pneumonia, you already know that he is at a higher risk for ASCVD in the future and coronary heart disease. You already know that he meets guideline indications for statin therapy. You already know that he would probably benefit from a primary prevention aspirin. You already know that if his LDL cholesterol, despite a high intensity statin, is more than 70, you would probably want to consider getting that lower. And if his blood pressure is more than 120, you want intensive blood pressure control. So in my case, this is incidental coronary calcium. It represents an opportunity for prevention. I would treat him with preventive therapies. I would discuss the risk versus benefit ratio for aspirin. And it is important to note that there's no data to support stress testing or invasive testing based on this CAC score. This is what we use at Johns Hopkins. So if anyone is found with incidental coronary calcification, this is what we send out to the radiologists and the referring physicians. We show them a picture of the coronary calcification, moderate to severe. We tell them consider initiating a statin if needed, or we have a subclinical atherosclerosis clinic for which they can place an order and have them see one of the lipidologists so we can have that risk versus benefit discussion on preventive therapies. Case 2. This is a 53-year-old man with a history of hypertension, obstructive sleep apnea, and 20-pack year smoking history, comes in for chest discomfort over the last 3 months. He's usually able to ride his bike for 1 hour, but says after 20 to 30 minutes, he starts feeling tightness in his chest. He takes lisinopril for blood pressure. His heart rate is 78, blood pressure is 132/84, and his EKG shows normal sinus rhythm. His labs are largely unremarkable. His total cholesterol is 220. LDL is 169. HDL cholesterol is 45. And triglycerides are 160. What is your next step? Do you start him on medical therapy and refer for an invasive coronary angiogram given his age? Do you order an exercise stress echo to diagnose stable angina? Do you refer for a coronary CTA and start medical therapy? And do you use nuclear stress testing? So the way I approached this case is, one, he's 53, he's a young guy. He doesn't have risk factors for having a lot of calcium in his vessels, but this is a clear history of stable angina. Every time he rides his bike, he gets chest pain, it's central, it's tight, and it's relieved by rest. And he has risk factors including hypertension, sleep apnea, smoking, and hyperlipidemia. Now, do I think that he needs to undergo invasive angiography? No, I don't think he needs to undergo it. It's reasonable if that's what's available. Do I think that he needs to undergo exercise stress echo to diagnose stable angina? No, from his history, I'm able to diagnose that this is stable angina, and there are medications I can use to improve his functional status. What about a coronary CT and medical therapy? How does it change my management? Well, it does. If I do a coronary CTA and he has left main disease, then that's a patient where I'm not just going to treat medically. I'm going to refer him for cabbage because he's having left main disease. That was not included in ischemia. And what about nuclear stress testing? I don't think it's unreasonable, but again, I think he has stable angina, and I want to make sure that we rule out left main disease, probably get an echo on him and make sure that he doesn't have an EF of less than 35%. And I think patients are more willing to proceed with coronary CT and less invasive tests for stable coronary artery disease once you explain the risk versus benefit ratio to them. Again, the others are not unreasonable, but from a shared decision-making standpoint and from a resource utilization standpoint, C would be the best answer. And again, this is the exact patient that the ischemia trial targeted. Last case, and this was a case that I saw in clinic, so it may be a little bit longer, but 73-year-old guy shows up to clinic and he tells me, Doc, I need cardiology clearance because I need to undergo an upper GI endoscopy. I look at him and I think, what are you talking about? This is not needed. But then I start asking him more questions and he says, you know what? My exercise capacity was excellent until 10 years ago when he visited the Bahamas and noted occasional chest congestion and belching. It was manageable until 2 years ago when he felt he was belching more and was having more episodes of chest pressure. So he came to the Johns Hopkins Bayview campus where he was evaluated. His cardiologist then started him on aspirin, a statin, a beta blocker, an ARB, and then he was discharged with follow-up. But the chest congestion and tightness on walking 2 blocks persisted. He would walk slowly and take 45 minutes to an hour to complete this distance. He had a pharmacological nuclear stress test with CT attenuation 2 years prior, and now you guys are experts in CT, and the CT attenuation helps with nuclear stress testing to treat, like some of the diaphragmatic artifacts and so on. And if you look here, this is his LAD, and you're seeing this is severe coronary calcification. So back then, you're already seeing that he is somebody who's at higher risk for future ASCVD. His nuclear stress test showed sub-millimeter horizontal to downsloping ST depressions in the inferior leads with mild reciprocal ST elevation in AVR and V1. However, his perfusion images were normal and his EF on the nuclear scan was 75%. In terms of lifestyle, really horrible lifestyle habits. For breakfast, he would have sausage and biscuit with cheese, coffee, bacon, egg, and cake. For lunch, you'll have a steak and salad. For dinner, he'll have chicken nuggets and chicken noodle soup. And for exercise, he used to ride his bike, but stopped because of the chest tightness about a year ago. And at his baseline, he was able to ride 3.5 miles. His medical history, he got a CAC score. His CAC score was 6,000. He had hypertension, type 2 diabetes, hyperlipidemia, a history of tobacco use, cocaine use disorder for which he stopped 2 years ago. And he takes medications including aspirin, atorvastatin, blood pressure medications, metformin, and alcohol, 2 or 3 glasses of Jack Daniels once every 2 to 3 weeks. This was his EKG. So I'll tell you, sinus rhythm, pretty good R wave progression. If you look at his precordial leads, you're not seeing any ST segment depression or elevation. You're not seeing any T wave inversions there. But if you start looking at AVL, again, T waves are upright. AVF 2, 3, upright T waves. So no real ischemic changes. So what is your approach for this patient? Do you just intensify his medical management? Do you get a coronary CTA? Do you refer for an alternative form of functional stress testing? Do you refer for invasive coronary angiography? Do you get a nuclear PET for myocardial blood flow? Or do you just tell him there's no need for cardiac clearance, proceed with endoscopy? So I sent him for a left heart catheterization. And if you look here, you're going to see that his distal left main is 99% occluded. So much so that when he was on the table, he started having angina, he started having ST depressions, and a troponin was done on the lab table, and a high sensitivity troponin peaked to greater than 25,000. If you looked at his right coronary artery, completely occluded, a proximal total occlusion. And again here, you're seeing distal left main and a bifurcation lesion going into his LAD and his circumflex and just diffuse disease. So this is a patient who has diabetes. He has stable angina, or one could argue it's starting to become unstable because he's having more symptoms now. He has a cardiac cath that shows left main disease and multivessel disease, and he's diabetic. The question is, why didn't I get a coronary CTA in this patient? These are not the patients that I'm going to get a coronary CTA in. His CAC score was sky high. There's going to be a lot of calcium. I'm not going to be able to really image to see if there's obstructive lesions. Again, he was having such severe symptoms despite being on medical therapy. So it's telling me that either I'm looking for left main disease or multivessel disease, given that he's diabetic, and that's surgically prognostically important information, that this is somebody that I'm not just going to treat with stents or medications, but somebody that I need to possibly get to CABG. And he was taken off the cath lab table, admitted to the CCU, and in 24 hours he underwent CABG, had a balloon pump placed leading up to the CABG, and then was subsequently discharged. So that's the end of my presentation, and I will open up the floor now for any questions.
Okay, Jelani, thank you for your excellent presentation, for sharing with us your interesting cases. Now we have the presence of two colleagues that have some questions about this topic. First, Dr. Auro Campos is my colleague. He works with me in the Hospital Nacional 2 de Mayo. Please, Aureo, go ahead with your comments. We are not.
First of all, let me say congratulations for your brilliant presentation. I would like to ask some questions. According to what you said, there are some features associated with high-risk events like low attenuation plaque, positive remodeling, napkin ring sign, and spotty calcifications. In your experience, which of these are more frequent and have higher risk of ASCVD events?
Yeah, I'm not sure I can answer the higher risk of ASCVD events. You know, from me looking at CT scans, I would say that I have seen a lot of the positive remodeling more. You know, I'm not sure in terms of the prevalence. You know, I can look up the data and get back to you in terms of the prevalence. But the positive remodeling is something that I see most often when reading.
Okay, and thanks. And the other questions would be, in which cases do you use FFR in CT?
Yeah, so it's a great question. So it all comes down to reimbursement. So I can tell you in Maryland, we do not get reimbursed for CT FFR. So none of the readers in Maryland use CT FFR. So when we're reading scans, we do not use CT FFR. We try to read it based on less than 50%, which is non-obstructive, 50 to 70% is moderate, and more than 70% is severe. The CT FFR is really for that 50 to 70% lesion. Think about it just like doing a cath, where you have that moderate lesion that you're not sure is obstructive and you want to get that answer. For us here in Maryland, it would be nice to get CT FFR, but I'm not sure it entirely would change our treatment, because as a cardiologist, seeing these patients and reading these scans, if it's 50 to 70 and with FFR, I'm thinking, do I either need to send this patient to cath or do I need to get more functional testing to build a story of what my management plan is going to be?
Okay, completely clear.
Okay. Thank you, Aureo and Jelani. Now we have the presence of Victor Celada. He's my colleague too. He works with me in the hospital 2 de Mayo. Please, Victor, go ahead with your question.
Buenas noches, chicos. Good night, Dr. Grant. I would like to thank you for your great presentation. Buenas noches. I would like to thank you for your great presentation. That was very interesting, very helpful for us. And also congratulations for your baby.
Thank you.
But I have one question, and it's related to your last case, because it's very frequent that we got multiple tools to evaluate the patient, or sometimes, for example, in our practice, elderly patients with pneumonia, like in the first case, with signs, symptoms of congestion. We saw the CT, the thorax CT, and we found calcium, and this could explain the signs and symptoms of heart failure. But also, when we continue with the studies, we found several lesions in the coronary arteries. But when we analyze these patients with ischemia tests, we don't find ischemia. No. How could we understand these findings, that we have a mismatch for saying that we don't have ischemia in some tests, but we see the severe lesions in the CT or in the coronary cineangiography?
Yeah, Victor, that's an excellent question. And it's something, Renato, nice to see you. It's something that, when I have my residents and, we discuss a lot on the floor. So the first thing is understanding calcified plaque and calcified lesions. So calcified lesions just tell me that you're going to have a higher risk of ASCVD in the future, and I need to optimize your risk factors. Start your preventive therapy, statins, blood pressure control, aspirin. But it doesn't tell me if there's going to be obstructive disease. So you can have a patient who comes in with heart failure and you see a lot of coronary calcium. All it tells me is that the burden of calcified plaque is high, but it doesn't tell me that that person has obstructive disease. So the first question that you're answering, just looking at the calcified plaque on a non-gated CT scan of the chest, is that patient needs preventive therapy. The second question that I think you're alluding to is, well, what if this patient is having heart failure and now they're having calcified plaque, and I think there's a higher probability that this may be related to ischemic heart disease? Then that might be a patient where either you get a coronary CTA, because you're trying to figure out to what extent is there obstructive disease, not just calcified plaque, but I want to know, are there non-calcified plaque that's causing obstructive disease, or are there not? So one scenario is you get this coronary CTA, and this patient has left main and multivessel disease that are obstructive, and with a reduced EF and heart failure, you'll say, you know what, maybe this cardiomyopathy is an ischemic cardiomyopathy. Another scenario is you would get a coronary CTA, and it shows non-obstructive disease, and you say, well, even though they have a lot of calcified plaque, they don't have much non-obstructive plaque, so this heart failure that they're having is likely not ischemic in etiology. The third component to your question, or that answer, is there's a really interesting paper that was done in Circulation earlier this year, and it was speaking to dual cardiomyopathy. And I don't know if it happens in your hospital, but a lot of times we have residents or interns who see that someone has a diagnosis of coronary artery disease and see that they have a diagnosis of heart failure, and it becomes chart law that they put ischemic cardiomyopathy. But it doesn't mean that because you have coronary artery disease, that that coronary artery disease is to the extent that it's causing your cardiomyopathy. And what this paper in Circulation proposed is getting cardiac MRI early in the testing process for these patients, because there may be some patients who may have one obstructive lesion or two obstructive lesions, and their EF is 15%, and it's global hypokinesis, it's not regional. And it may just be that you have two things happening. You can have a non-ischemic cardiomyopathy, but also have coronary artery disease, but it doesn't mean that you're classified as ischemic cardiomyopathy. So to answer your overall question, understand that the calcified plaque just tells me about your burden of plaque and your future risk of ASCVD, and it's going to inform preventive therapies, nothing more. It doesn't tell me about obstructive lesions or obstructive plaque. Getting a coronary CTA or an invasive cardiac cath will give me that answer in terms of heart failure. Is the extent of obstructive disease right enough and matches the wall motion abnormality that I can call this an ischemic cardiomyopathy? And if you're not sure if this patient is just having some coronary artery disease and heart failure, but one is not causing the other, a cardiac MRI is a useful tool if you're able to get it to help figure out if there's a non-ischemic component to it.
Thank you, Dr. Grant.
Okay, and now we have the presence of Renato Quispe. He's my colleague. He studied with me in the University Cayetano Heredia, and now he's on Johns Hopkins Hospital doing a fellow in electrophysiology. Well, Renato, go ahead with your comments, please.
Thank you for the introduction, and thank you, Jelani, for joining, and congratulations one more time for all the amazing work that you have done. I'm sure you can talk for hours about this topic, and CAC score is still a novel topic for some areas and some countries like Peru, and I'm sure Trinidad is the same. Even more novel than that, extracoronary atherosclerosis is a very novel, unique field that now you see more and more papers coming up. Can you make a comment on it?
Yes, great question. So we worked on a review article probably 6 to 8 months ago talking about coronary calcification and extracoronary calcification. And what Renato is alluding to is that the same way that you can get calcium deposits in the intima of coronaries, you can get calcification of the aortic valve, you can get calcification of the thoracic aorta, you can get calcification of the abdominal aorta, you can get breast arterial calcification. Right now, the best data that we have is for aortic valve calcification and abdominal aortic calcification. So similar to looking for incidental coronary artery calcification, there's a lot of work ongoing now that when I look at patients, even if I'm doing a TEE or I'm doing a CT, if I see calcification in the abdominal aorta, that's also an indication for statin therapy, and that's supported by guidelines. So you're seeing calcification in the abdominal aorta. It behaves similarly to the coronaries in terms of atherosclerotic plaque. You can treat that. The thoracic aorta is less so. So I'm not sure how strong the data is on treating calcification in the thoracic aorta, but definitely for the abdominal aorta. In terms of breast arterial calcification, there's a lot of data that if you're doing a mammogram, you're able to calculate the amount of calcification in the breast arteries. And patients or women who have more breast arterial calcification, it correlates, so it's associated with a higher risk of coronary heart disease. The problem is that there is no standardization, like what equates to low, intermediate, high risk of breast arterial calcification, and what's the cutoff of treating with statin therapy. So for right now, in terms of breast arterial calcification, we just know that if there's more breast arterial calcification, your risk is higher, but we don't know what to do with that. At what point do we start treating? Interestingly, there's a paper that should be out very soon where dental radiologists are looking at dental radiographs. So you go to the dentist and they take an image of your mandible, and they're looking at your carotid area on that X-ray to look for calcification in your carotid arteries. And there's a really good correlation between the dental calcification and coronary heart disease. And there are recommendations from the Dental Society that, one, if they see it, they should report it. And two, once it's there, you should check their lipid panel and so on. And it could inform starting statin therapy. So I say all this to say that Renato raises a great point, and I thought about putting it in the slide, but I didn't want to overwhelm you guys with a lot. But it's more than just coronary artery calcification. Remember, we spoke about the 3 types of calcification, and it's intimal calcification which leads to atherosclerosis. And atherosclerosis can occur anywhere. It can occur in the coronary arteries. It can occur in the carotid arteries. It can occur in the abdominal aorta. It can occur in the breast arteries. And for right now, we have the best data for abdominal aortic calcification for treating, and the carotid. But otherwise, there's more and more emerging data of where are we finding calcification and what can we do to treat
I had just one more question, and this is more for the panelists. I wanted Jelani to kind of listen or hear from you guys what you guys are doing, what type of patients you are referring for coronary calcium score, and how often you see that done in your practice.
Let me answer Renato the question. Recently, I had a patient at the clinic with some risk factors like high blood pressure and diabetes. He has a typical chest pain and a high LDL cholesterol. I gave him the order to perform a CT scan, but the insurance did not allow up until I performed exercise stress test. So in my experience at the clinic, most of patients who require a CT scan because of the insurance, they want first for us to perform an exercise test for reimbursement purposes. That's at the clinic. At the hospital, we do not really have the ability to perform CT scans in a routine way because, as you know, in our country, our centers do not have neither the experience nor the resources to perform CT scan to all patients. So these are reserved for in high intermediate patients in outpatient setting.
So that's interesting to know. And, I think, Renato, it's great that you posed that question because I didn't know that one. And it's shocking to me in one sense that I feel like we live in this bubble in the US, in Baltimore, where it's easy to get these things. But for me, I'm originally from Trinidad and Tobago, and it's the exact same experience that you guys have, right? Which is, it's all great for me to talk about CAC scoring and coronary CTA and how easy it's done at Hopkins. But, similarly in Trinidad, I speak to my friends or my colleagues back there. It's a headache to get it done. What about CAC scoring? Are you guys able to get just simple CAC scoring to look for calcium done, or? I think you're muted.
Okay. The CAC score is more simple, it's more economic. We have this in the clinic and in the hospital too, but we have the information about this topic, but we have some problems in the hospital with the economic problem. So we prefer to treat these patients with statins.
Yeah.
We don't have the information about the CAT score or the CT, many times.
Yeah. Is it possible? Have you guys been in the habit, or has anyone been looking at the calcification on non-cardiac CT? So if they have a CT scan done for other reasons, do you guys look at those scans for calcium?
Yes.
Yes.
Yes, we have patients with other diseases, for example, pneumonia and other things that we have in the emergency.
Yeah.
And we see calcification in other parts, and we treat with these statins.
Yeah, I think in a setting where it's difficult to get that dedicated CAC score, like I think it's huge. Like every patient who I see, I think most of them, Renato, you can correct me if I'm wrong, most of the patients we see, somebody has ordered a CT scan for them in the past. And it's just very easy for me to look back and identify that. And it means I don't have to send them for a separate test, but it does help me in terms of what is their risk and how aggressive I need to be with preventive therapies.
Giancarlo, Victor, and I work at a general hospital, so it's usual to perform chest CTs for other reasons, for other indications. We have patients with pneumonia or maybe with heart failure who are not diagnosed with chronic coronary disease, but if we see classifications in coronary arteries, we start statins and aspirin.
Yeah. Awesome.
Yes. Well, Yelani, thank you for your awesome presentation. You gave us a lot of information about this topic. Thank you very much again. And sorry for your problems with the translator.
It's fine.
And we hope to have you again in these presentations, okay? And you are welcome to Peru when you want to come here, okay?
Listen, two of my best friends in residency were Peruvian, and Renato is a good friend of mine. So I want all the pisco sour, I want all the lomo saltado, the Renato, what's the one with the yellow chicken, the egg, the rice, ají de, all of those things.
Ají de gallina.
Ají de gallina.
Okay, so you're welcome to Peru.
Of course. And you guys have my email, so please, if anyone has any questions or just wants to discuss anything, like feel free to email me.
Okay. Thank you, Yali. Thank you.
Have a good one.
Bye.